Here in New Orleans at ASH 2013, we have with us Andy Artz, MD, from the University of Chicago Hospital, where he is a hematologist and transplant physician. Thanks for joining us, sir.
Thank you.
All right, so you were on the faculty of an education session in high-risk MDS and AML. For those who weren't able to get that hot ticket, what can you tell us that was about?
Well, they missed an exciting session, for sure. The session really focused on the fact that in high-risk MDS and AML patients where we want to pursue allogeneic transplant, the different ways we can optimize outcomes. The first session by Dr. Von Bazine looked at better ways to select donors and ways to minimize the long-term complications of GVHD that still might lead to favorable outcomes for the patients. The second session was by Dr. Charles Craddock, who discussed different conditioning regimens and different ways after transplant we might mitigate relapse, which is a major problem for these high-risk diseases. Even though you undergo an aggressive treatment, the disease can still return. And there are many attempts looking at ways to ameliorate or reduce the risk of recurrence. And in the session that I did, we addressed taking older adults to transplant with MDS and AML, how we can best select the patients and best select the donors.
What would you say some of the key takeaways were?
The key takeaway for the older patients are that, first of all, older patients, we need to look at their health status in a very broad way. So we've looked at comorbidity, and we know that higher comorbidity is a risk for doing worse after transplant, but we can still get those patients through transplant even if they have significant but not severe comorbidity. It seems that other measures of functional status are quite important, if not more important. And therefore, when we evaluate patients coming to transplant, we can't focus on comorbidity alone, but we have to look at their global health to really know how they'll do after transplant.
So really you're looking at expanding how you measure things, but have to figure out which areas are best, right?
That's exactly right. We need to do a more comprehensive evaluation of the patient. Just as we comprehensively evaluate the leukemia, we do cytogenetic studies and molecular studies and comprehensive evaluation of the donors. We HLA type them at many loci and look at different features. And the patients now, more than just comorbidity, we need to look at different measures of function, if not cognition and social support, in a formalized manner, and that may allow us to expand the number of older adults eligible for transplant while also selecting against the few that would do poorly.
Now, Andy, you mentioned the number of people over 70 getting transplants has risen dramatically in this century. Why is that, and what types of new challenges does that present?
It's really quite amazing that in the 80s, our limit may have been 50, where not many people over the age of 50 received a transplant. And in the 90s, not that many people in the 60-plus category were undergoing an allogeneic transplant. And in the 2000s, the 70 age group seemed to be the barrier, and that's now being overcome such that there's almost a 9-fold rise over the past decade in the number of patients 70 and older undergoing allogeneic transplant. There's still a small number of patients compared to the large pool that actually have these diseases, since the diseases are very common, but it's rising markedly, and I think that has to do with not just our ability to get patients through transplant. We're becoming more comfortable with taking these patients through transplant, and there's some factors outside of the transplant doctor's hands that is, as baby boomers get older and this generation actually comes in to treatment much healthier than generations before. Some of these patients have been exercising vigorously, some are running marathons at age 70 before they're diagnosed, and they don't need to be excluded from transplant. They have quite good function.
If there were any questions that stood out from the sessions, what would you say they would be?
I think one of the best questions that was posed to me was, fine, we did a full assessment, we call that a geriatric assessment, and we can risk stratify, find groups of people who do less well and those that do better, but what are we going to do in the future? That doesn't improve the outcomes of the patients we're taking to transplant, and that's exactly right. So what we're doing at our center, and I believe other institutions are starting this as well, is we do a full assessment called a geriatric assessment, and then we use that information in a multidisciplinary clinic where we look at cognition, nutrition, social support, comorbidity, and functional status, and then we apply a supportive care package targeted to the vulnerabilities we find. If someone walks a little bit slow and reports that they're not as functional as they had been, we start early physical therapy. If their eating is suboptimal and they're losing weight, our dietitian makes recommendations. And some people have some subtle cognitive impairments that we find. They're still transplant candidates, but we make sure they have a very strong social support in case they have problems after transplant. And we also look at medication avoidance strategies.
Very good. Andy, thanks for stopping by.
Thank you so much for your time.
Very good.